Here at the annual ASH meeting, I have presented this morning a oral presentation on the role of Ixazomib as maintenance therapy. We performed a trial through the Multiple Myeloma Research Consortium with multiple medical centers, wherein patients initially got chemotherapy, then went to stem cell transplant. After stem cell transplant, these patients got consolidation chemotherapy with a combination of Ixazomib, lenalidomide, and dexamethasone for 4 months. We already reported at the ASH meeting last year that this led to a deepening of MRD negative complete remissions, and so that was the primary endpoint of the study. But after the period of consolidation chemotherapy, patients are randomized to either lenalidomide alone, which is the standard of care based on several trials that have been done in the past, or Ixazomib. Ixazomib too has been studied before and reported at the last ASH meeting and compared at that time to placebo, and did show superiority to placebo. In this trial, we were actually starting to compare head-to-head the lenalidomide and Ixazomib as maintenance. And in this trial, what we accrued were close to about 100 patients in each arm of the study. These patients were placed on either lenalidomide or Ixazomib. And what we found was that both arms of the study tolerated the drug reasonably well. There was slightly different toxicity profile. There was a little more in the way of bone marrow suppression when you got lenalidomide. There was, however, a little more in the way of gastrointestinal toxicity when you got Ixazomib. The trial was recently reviewed by our Data Safety Monitoring Board, and it was decided, though there was no firm evidence that one arm was doing better than the other, to just discontinue the arm that was getting lenalidomide, because we, based on our statistical power, did not think that we were going to be able to show that the drug was equivalent or inferior or superior to lenalidomide. And since lenalidomide is an established standard, we felt it best to go ahead and let patients go on to lenalidomide. Patients or their physicians who felt that patients were benefiting by Ixazomib could stay on the Ixazomib, and several patients have actually chosen to do so. Also, patients who cross over to lenalidomide but have issues regarding tolerability will be allowed on to the Ixazomib arm. So this trial will continue to be following patients, and we will, I think, get more information on how patients do with prolonged Ixazomib maintenance for those who remained on Ixazomib, but also very valuable information for about those 1/3 of patients that cannot tolerate lenalidomide as maintenance as to how Ixazomib does for them. So this is a study that we will continue to follow and update in the coming years, and hopefully we'll get even more information.